One key mutation, of course, is KRAS, which is mutated in about 40% of patients, and certainly of interest because it defines who should be getting cetuximab or panitumumab, that is, only wild-type patients should be receiving that drug. And we've now learned from more recent studies that you should expand your study of KRAS to include not just codons 12 and 13, but to include codons 61 and 146, because all of these seem to have the same effect of mutation, and moreover to include the sister of KRAS, NRAS, and then by virtue of doing the composite of all of that, you really then weed out the true wild-type patients who appear to have the greatest benefit to cetuximab or panitumumab. So I think it's an important recent area investigation saying, yes, all patients should be genotyped. They should be genotyped for all the mutations in KRAS. They should be genotyped for the mutations in NRAS. And then if they're truly wild type, that's probably the population that you ought to consider using an EGFR antibody. So obviously that's really important. Realizing how key KRAS is, you would say, well, this should be the target of drugs. And it obviously hasn't escaped anybody. The problem is that defining drug targets against mutant KRAS has been impossible. It seems, maybe undruggable. But I think what's happening now is people are doing additional studies looking at downstream pathways in a way to understand the Achilles heel of KRAS mutation. So I think what we'll see in the coming years are some newer studies, new sort of better defined studies to target KRAS mutant colon cancer, but using a different strategy, that is hitting the downstream events as opposed to trying really without success to target KRAS itself.